malignant tumors of your salivary gland. So, first we have your mucoepidermoid carcinoma. Now, this is your most common salivary gland malignancy occurring in children and your young adults. The peak incidence is in your second decade of life. It usually occurs after your radiation or chemotherapy in childhood. It presents as a soft to firm, painless mass which gradually increase in size. The most common size of your distant met is your lung. The treatment would include your surgical excision and an adjuvant radiotherapy. Now, demonstration of at least focal intracellular mucin is essential for your diagnosis of your high grade mucoepidermoid carcinoma. So, these are your few important points with respect to your mucoepidermoid carcinoma. Now, this is an image showing your mucoepidermoid carcinoma of your hard palate. Right. Now, moving down to the next important malignancy is your adenocystic carcinoma. Now, these are slow growing malignancy. Now, they have your high predilection for your perineural invasion. It is much more common in females compared to your males. Now, it usually presents in your 5th to 6th decade of life. Now, nodal metastasis occurred in your high grade lesion, and your treatment would again include your radical surgical excision with plus minus adjuvant radiation. Now, your IHC shows over here the ductal cells to be positive for your c-KIT and your myoepithelial cells to be positive for your p63 and your SMA. So, these were the few important points for your adenoid cystic carcinoma. Now, moving down to the next malignancy, we have your actinic cell carcinoma. Now, they are low to intermediate grade tumor with majority occurring in your parotid gland. The peak incidence is seen in your 5th decade, again being much more common in your females compared to your males. Now, the high grade tumors have your metastasis to mainly to lungs and your nodes. Now, the treatment would include your complete excision with your adequate margin. Now, the IHC is DOG1 and SOX10 positive and it is negative for your mammaglobin. Please remember this IHC markers of your salivary gland cancers. Now, mitosis, necrosis or nucleopleomorphism is quite rare to be seen in your histopathology, helping it to be differentiating it from the other HP images of your salivary gland cancers. Then we have your carcinoma ex pleomorphic adenoma. So, what it is? It occurs in association with your pleomorphic adenoma. The carcinoma component can be either purely epithelial or purely myoepithelial. It is most common in your parotid gland, again much more common in women compared to your men, occurring in your 6th decade of life, and the treatment being your radical surgical excision plus minus your adjuvant radiation. Now, there is a T53 mutation and amplification of HER2 which has been seen and associated with your carcinoma ex pleomorphic adenoma. Right. The next we have is your salivary duct carcinoma. So, these are again your high grade adenocarcinomas. They arise de novo or as a malignant component of your adenoma. Now, they mostly again occur in your parotid, seen in your elderly men, right, and in the 6th and 7th decade is the peak incidence, and your treatment would include your total parodectomy plus neck dissection. Now, what do you find in the HPE? You find a comedonecrosis, cribriform pattern, Roman bridges like features and vascular and your perineural invasion. So, this were the few important points for the specific types of your salivary gland carcinoma. Please remember the most common is your mucoepidermoid carcinoma, and having a predilection for your perineural invasion is your adenoid cystic carcinoma. Right. Now, coming down to the imaging, we have your CT scan. So, now CT scan is good to differentiate your neoplasm versus your inflammatory condition, whereas MRI is good to differentiate your benign versus your malignant changes. And we have your HRUSG, which are good for your inflammatory conditions as well as for your sialolithiasis. Right. Now, we do an FNAC for the parotid tumors, right, or the salivary gland tumors, because it has a good sensitivity of your 80% and a specificity of your 97%. Now, for reporting of your salivary gland cytopathology, there is a system which is your Milan system, right. So, category 1 is your non-diagnostic, which has a risk of malignancy around 25%. Now, you usually the usual management would be clinical and radiological correlation or repeat FNAC. Then the non-neoplastic risk of malignancy being your 10%. Again, over here you would be requiring a clinical follow-up and your radiological correlation. AUS, which is the RTP of undetermined significance, the risk of malignancy being 20%. So, you need to repeat FNAC or go for a surgery. Now, in case of category 4, 4A is benign, which is risk of malignancy less than 5. You need to go for a conservative surgery or a clinical follow-up. And in case of 4B, which is your sum, that is salivary gland neoplasm of uncertain malignancy having a risk of 35%, you need to go for your conservative surgery. Now, if it is suspicious of malignancy, that is a risk of 60%, you go for a surgery, and if it is malignant having a risk of malignancy more than 90%, then you again plan for surgery. So, this Milan system of reporting of salivary gland cytopathology has been a new entrant into your Bailey and Love 28th edition. So, please do remember this, and the most expected question that we expect is definitely your Milan system is used for salivary gland cytopathology, and we have discussed this table to give you an extra edge over here, right. Then we have your staging of your parotid gland tumor. So, again the standard T staging, which we have taken from the TNM staging, and the table has been taken from your Bailey and Love textbook. So, we have your T1. Now, what happens in T1? Tumor is 2 cm or smaller in your greatest dimension without any extra parenchymal extension. Then we have T2, where your tumors are larger than 2 cm, but not greater than 4 cm in your greatest dimension without any extra parenchymal extension. So, please remember T1 and T2, there is no extra parenchymal extension. T1 less than 2 cm, T2 2 to 4 cm. Then we have T3 larger than 4 cm and having your extra parenchymal extension. Then we have T4A, which is your moderately advanced disease invading the skin, mandible, ear canal and facial nerve. So, the important question that is asked is involvement of your facial nerve is T4A. Then your T4B is your very advanced disease that is invading the skull base, pterygoid plates and encasing your carotid artery. So, involvement of your facial nerve and your mandible is T4A, whereas involvement of your pterygoid plates and your skull base is your T4B. So, these are your few important questions that are often asked in your clinical scenario. So, please do not get confused between your T4A and T4B. Now, the treatment would include your surgical excision and a margin of at least a 0.5 centimeter. So, for a submandibular gland tumor, you would going for a submandibular gland excision, and for a parotid gland tumor, you would be either going for a superficial parodectomy or a total parodectomy. So, we shall be discussing regarding the surgeries in a separate video, where we shall also discuss a few important complications and the important nerves that have to be saved during your submandibular gland surgery. Thank you.